Thank you very much for your patience. But now it's time to turn our focus to clinical governance under the new Aged Care Act. And in this session now we're going to hear about why the delivery of safe aged care is simply not possible without a strong clinical governance approach. And we're going to explore with the panel that we have now on the stage what this looks like in practice. So once again, I'm sure they'll just identify themselves as I mentioned their names, but our panel for this session is Paula Pearsall, Executive Director, Chief Clinical Advisor Division, and also Dr. Mandy, Callary, Chief Clinical Advisor from the Commission. Then Dr. Anthony Marinucci, Specialist GP and Generalist Aged Care Practitioner. Dr. Tim Henwood, Principal Consultant, AgeFIT Solutions. Joe Boylan, Chief Executive Officer, Clayton Church Homes. And Anna Lygopoulos, member of the Commission's Consumer and Families Panel. So Paul is going to facilitate this session, and of course, again, a reminder, as you have been doing, to facilitate the conversation, please do submit questions via the conference app or, of course, the microphones in the room. Over to you, Paula. Thank you.
Fantastic. Thank you so much, Richard. And good afternoon, everyone. It is my absolute pleasure to be here with you today. Was that me? Okay. Right, yes, okay. So as I was saying, it is an absolute pleasure to be here with you today and to be a part of a session that I know will generate much thought and also discussion. So I am very much looking forward to unpacking with our panel and with each of you what clinical governance really looks like and why it's important through a very practical lens. The panellists here today will be bringing a set of what I describe as unique and complementary perspectives, talking about their personal insights and experiences. Just to reiterate some of the comments that Richard made and consistent with practice to date, we will have time for Q&As towards the end of this session. And once again, you're welcome to go to the microphone or to submit those questions via the app. So just in terms of moving into the session officially, I would like to invite the panellists to once again introduce themselves and to also touch on their roles and or the capacity in which they are appearing today. So if I can start with you, please, Anna, that would be fantastic. Thank you.
Thank you. It's a pleasure to be here. My name is Anna, and basically the reason why I'm here is I've had a bit of experience in the aged care sector in that I did stop working a few years ago to look after my two elderly parents, both of whom have home care packages, level 4 and level 3. And that was quite an eye-opener. We started from the beginning, from the first call to my aged care, all through to the assessment, through to getting the packages allocated, and then of course going through an interview process to interview and shortlist the home care providers. And then again, in partnership with the care manager, managing both of those two packages, both of which needed not only the shifts that needed to be managed, but also the rental of equipment and furniture and the ordering of products. Aside from that, I also volunteer twice a week. I visit two elderly ladies for companionship, which I really enjoy, and that's sort of through them I hear stories and opinions and a whole lot of experience about aged care. And I also co-chair the consumer advisory body of the home care provider of the two packages that my parents have. That's the reason I'm looking forward to having this discussion. Thank you.
Thank you, Anna. And I'm Dr. Mandy, Callary. I'm a geriatrician, and I'm also the Chief Clinical Advisor for the Aged Care Quality and Safety Commission. And my role and that of my division within the Commission is to raise awareness of clinical issues within the sector and to promote best practice in both clinical and aged care.
Jo Boylan. I'm newly retired from a chief executive position and taking on my greatest passion, which is to move healthy ageing very prominently into aged care, particularly in the nursing area. For the last 35 years, I've worked really to make healthy normal in aged care. Along with Tim, I've put gyms into all of the aged care organisations that I've worked with. So it's been an absolute privilege to do that.
I'm Dr. Tim Henwood. Good afternoon all. I run an organisation called AgeFIT Solutions, which is aimed at bringing health and wellness opportunities to every older Australian. I'm an outspoken advocate for reablement and wellness, and as Jo mentioned, healthy ageing and some of the stuff you're going to hear me bang on about very soon.
Good afternoon, everyone. My name's Anthony Marinucci. I am a full-time specific interest aged care GP in metropolitan Sydney. I'm Medical Director at Geriatric Care Australia, and we're a group of GPs, geriatricians, nurses, passionate admin staff who like to find aged care providers to collaborate with and really innovate in models of care, because we really feel that sort of collaboration is the key to outcomes. Outside of clinical work, I'm the College of GPs Aged Care Chair, and I'm involved in lots of guideline and policy advocacy in the aged care space. So looking forward to contributing today. Thank you.
Thank you. And when you use the word experience, I wasn't kidding, was I? We've got a very well-informed panel here. And so, Mandy, without further ado, if I can hand over to you, Mandy will be taking us through a case study, and that will be used as the foundation for at least a key component of the panel discussion this afternoon.
So I'd like to introduce you to Ruth. She's a 91-year-old widow who's recently moved into care. Now, she's an accomplished woman. She's a retired nurse, mother of 5, and still actively involved in the mission of her church community. She's also fiercely independent, but has become housebound by virtue of her severe arthritis. And there has been increasing fatigue and weakness and a series of falls, and it seemed inevitable that Ruth would move into care. She's also someone who is careful with her body, vegetarian, preferring physical therapies to drug therapies. So I first met Ruth when she was referred to me for a memory assessment. She'd scored poorly on a memory test, the sort that most older people are subject to when they first enter care, and she was really quite concerned that she had dementia. But there were some other issues. Since her move into care, her right knee pain had significantly worsened. She'd become quite constipated and she'd lost interest in food, and there had been some weight loss, which is never a good thing for an older person. And I guess from my point of view, thankfully, I was very quickly able to reassure her that I didn't think she had dementia. But what of her other ailments? So I sat down with Ruth and I asked her why she thought her pain had worsened, and she knew immediately. She thought that her pain had worsened because she was no longer able to heat her wheat bags. She was no longer able to heat her wheat bags because she wasn't allowed to use a microwave in the nursing home. Because her knee pain had worsened, she'd reluctantly agreed to take some Panadine Forte. So Panadine Forte is a medication that includes codeine phosphate, which is really well known to cause constipation and can often cause reduced appetite. But there were other factors contributing to her poor appetite. There were limited vegetarian meal choices, and because she wasn't allowed to use a microwave in the nursing home, she wasn't able to prepare her own meals herself, and she'd become quite depressed. And of course, the one question that was on my mind at the time, as I'm sure it's on yours, is why wasn't Ruth allowed access to that microwave? After all, she'd been safely using a microwave in her own home without supervision or assistance right up until the time that she'd entered care only 3 months prior. So Ruth's circumstance is really a good example of dignity of risk, where dignity of risk is the idea that self-determination and the right to take reasonable risks are essential for dignity and self-esteem and should not be impeded by excessively cautious caregivers concerned about their duty of care. When dignity of risk is not respected, it not only results in poor quality of life outcomes, but it actually can also result in poor clinical outcomes. And so in Ruth's case, she had more pain, she had weight loss, and she had become depressed.
So a few months later, Ruth contacted me again. On this occasion, she had quite severe pain, but this time not in her knees, it was actually in her back. She'd fallen a few days earlier and suffered a pelvic bone fracture. She was now requiring use of a sling lift and assistance for 2 members of staff to move in and out of bed. She told me that she wasn't getting the right care in the nursing home and that staff did not care about her. She told me that she wished to die, and family were in fact wondering if a palliative care approach was now more appropriate. And Ruth was still waiting to be granted permission for that microwave.
Thank you, Mandy. Certainly paints the picture, doesn't it? It does indeed. So I would now like to ask each of the panel members to reflect on the case study and to share what comes to mind for you. So once again, if we could please begin with you, Anna.
Thank you. Obviously, I'm not a doctor, but I have had some experience from family and friends and my own experience attending residential facilities. In this case, it doesn't surprise me that this situation has occurred. I think it was like a domino effect. You know, something as so simple as using a microwave. What did stop the staff from letting her use them or supervise her once a day or twice a day to heat that heat pack? Heat pack, I think I tested mine, it was 2.5 minutes to heat mine last night. So really 2.5 minutes by twice or 3 times a day would be nothing. The simple things like that, from my point of view in this case, is that a lot of the time when people move into these facilities, they're meant to, or they're expected to be like a one-size-fits-all. And we know that people are different and they have their own requirements. And sometimes the fear that staff have, the fear of liability or risk, or these really serious words that their managers use because they're worried about what might happen, we might get sued, seem to get in the way of providing quality care and humanity. And Ruth lost her essence because she was obviously very independent and capable just before, and so people made assumption about her without actually observing her, chatting to her, and seeing exactly what she was capable of doing. Something simple could have possibly prevented this domino effect, which led to that outcome. So I suppose the staff, which usually there's never enough of on a shift, is usually what we hear from, you know, residents, family and friends. They're too transactional in their processes. At this time, I've got to do this, I've got to do that they don't have time to get to build relationships with the residents, to know them, and to really, more importantly, observe them, to see this person's losing weight, this person's getting depressed. What are the underlying factors that have caused these things? So this doesn't really surprise me. I think it happens all the time. It's not an exception. And, you know, I think that if there was some way potentially to have that, the rights of each resident respected and obviously communicated and shared, perhaps something like this could have been avoided.
So Ruth's story to me is a story about frailty and how frailty behaves. So frailty, I know, is a bit of a vexed term in the aged care sector. Most older frail people don't identify with being frail. They don't like to be called frail. But from a clinician's point of view, it tells me a great deal and actually kind of kickstarts my approach to managing that older person's care needs. So what is frailty? So frailty is a state of increased vulnerability which results from an ageing-related decline in reserve, such that the ability to cope with sometimes even everyday stresses is compromised. And what that means is that frail older people have an inherent increased risk of poor health outcomes, even despite our best efforts to mitigate those risks. We know that Ruth is likely to be frail because she's in her 90s and because she's become housebound. We know that she's likely to be frail because she describes herself as being slow and weak. She's also very likely to be frail because she's had those falls. And frailty is also associated with a greater likelihood of suffering side effects to medication, and that was certainly Ruth's experience. But perhaps most instructively, we can also tell that Ruth is frail because of how easily she experienced decline following her move into care. It took only one seemingly small lapse in care, being unable to heat her wheat bags, which led to a disproportionate negative impact upon Ruth. This led in turn to further complications, and things went from bad to worse pretty quickly. The problem then is that once this has occurred, it is often very difficult for frail older people to regain the ground that they have lost. And it even gets more complicated. We also know from our experience in health, for example, that it's not just what care is provided, or not provided for that matter, but how that care is provided that also can negatively impact frail older people. And that such is the nature of frailty in any setting. So frailty is complex, and it can be challenging to know how to translate the concept of frailty into aged care practice. But there is a way. Evidence shows us that frailty can be managed. In some cases, frailty can be reversed. There are many tools and guidance available, and new Australian frailty guidelines are soon to be released. But I will leave it to our other panellists to talk more about how this might be achieved.
So proudly put up your hands if you're a registered nurse. Oh, that's a lot. There's a lot. Well, you are the superpowers of aged care. Really, you're the superpowers of healthcare. You have the ability to shape great outcomes. For poor old Ruth, though, I'm not sure the nursing superpower was working. And nurses did not provide Ruth with the opportunity to prevent her avoidable decline. And this is actually common in aged care. We have yet to adopt the mindset that is required for a true human rights approach to giving people the opportunity to recover from frailty. So when I hear Ruth's story, I think the nurses and others in the home missed what was important to Ruth and the acknowledgement of her diverse experiences. Ruth was a great character, a mother, a nurse, and she wanted to be a partner in her care. However, there was low effort. You know, when we look at proportionate risk, we also have to look at proportionate effort. There was low effort and engagement into what Ruth cared about. And subsequently, what happens then is you get substandard care or a substandard outcome. Not intentionally, it's unintentional. But this prevails thereafter. And then you have to try and catch up with it because it escalates very quickly. Even basic care planning expected of nurses was not provided to Ruth. Proper pain charting, proper pain management, bowel charting, bowel management, even a Cornell. There were a lack of problem solving for Ruth. It would have been so easy to check and support Ruth and her ability to manage a wheat bag in a microwave, as this was the most important thing to her. The third big setback for Ruth was that no one had stopped to look at what was actually working here, what was not working here, and how they could move Ruth back onto a more positive trajectory. She kept on declining and going into a negative trajectory. Now, you know, as nurses, because we are superpowers and we shape amazing outcomes when we want to, we should get really upset when we see these negative trajectories when they can be avoided. This is transactional nursing. I'm a registered nurse, I know. There was no clinical reasoning or clinical judgment, therefore no plan for improvement. Ruth's health and quality of life declined further and she wanted to die. She could not get anyone to see her or what was important to her, but had the strength to reach out for external help. Over to you.
just going to repeat everything all they've said. So to me, this case is a massive but incredibly common missed opportunity in the residential aged care setting to support the resident to be the best possible version of themselves. So Ruth's wants are highly documented. I would suggest they're through all the paperwork in the residential aged care facility. The simple task of going and heating up her wheat bag, but for some reason, whether it's some silly safety policy or it's because residential aged care facilities are incredibly busy doing other tasks or doing other complicated safety daily services, Ruth's wants were denied. And by denying her wants, that became the catalyst to the spiral in her decline. So the evidence shows us that when an older adult becomes sedentary or when they take themselves out of a normal physical active behaviour environment, what always follows is physical, social and mental health decline. So the evidence also shows us that on average, a residential aged care adult moves, walks or mobilises for only about 20 minutes of their waking day. And so often this is even the resident's choice. They choose to not attend the dining experience. They choose to not go to the crafts class or the exercise class. They choose to stay in their own room. But eventually they have such physical decline, they've got no choice but to remain sedentary in their own rooms. We also know from evidence that when somebody sits and is in bed rest for an entire week, they can lose as much as 50% of their functional well-being. And it's not just their functional well-being they're losing, but their risk of falls skyrockets, so does their risk of pain, so does their susceptibility to disease, so does their cognitive decline starts to escalate as well. And all these things are common in Ruth's case. So what Ruth wants is to heat up her wheat bag. What Ruth needs is a staff member to assist her to mobilise from her room to the microwave, assist her to heat that bag and assist her to come back to her room, no matter how long it takes and no matter how many times she wants to go per day. What she then also needs is to culminate that trip, not in a trip back to her room, but a trip to the dining room so that she gets social engagement, in a trip to the crafts class so she starts to meet other people in her facility. And in mobilising with that staff member, she should be engaged in conversation. And the staff member should be taking advantage of that time to get to know Ruth, to develop a relationship. And Ruth should be treated with autonomy and not meant to feel like that staff member is in that transactional task space that we've already talked about. So I do realise that residential aged care facilities are a very task-driven environment, but it's important in cases like this that we need to break that. So by doing this, by helping Ruth mobilise to that microwave, heat up her wheat bag, we are not just mobilising her, we're also helping her work on her muscle mass, her mobility strength, her ambulation, breaking down her falls risk. You know, there is other alternatives that I believe are far better activity and exercise alternatives for an older adult in a residential aged care space. But this is far better than nothing to keep her moving. And then on the back of that, as I mentioned, she's going to the dining room, she's socially engaging. We're getting blood pumping through her body and her brain. And all of a sudden, she's actually experiencing better cognitive health as well. So then Ruth is getting what she wants, what she needs, and we're also defending the dignity that she deserves to have defended as well. So in short, as much as Ruth's story is a common story of decline, I suggest it is avoidable. So I won't go so far as to say just by mobilising Ruth to a microwave and back, you're going to protect all the things that are going on with Ruth. But I will also go so far as to guarantee this needs-based approach will make Ruth feel incredibly heard and incredibly acknowledged. And when she is heard and acknowledged, she'll also be happier, more comfortable, and more engaged in her home.
Do you mind if I just add on a little bit more? Sorry, we can talk about this until the cows come home, can't we? So rather than just problematise, which I was doing before, Ruth should have been placed on a recovery pathway as soon as she entered the home. And that coordinated care right from the get-go, has to be in the nurse's mindset. My job is to improve this outcome for Ruth, these outcomes for Ruth. That was missing, absolutely missing. For someone like Ruth, we could have avoided the pelvic floor fracture probably if we'd gone on to this more intensive exercise right from the beginning to get Ruth back into to shape. Probably what you're saying, Tim, is absolutely correct. Just walking backwards and forwards to the microwave would... No, you'll be there, Anthony.
You're in the gym, Joe.
So the other thing is, you know, establishing gyms is what we've been doing for the last 35 years in all of our aged care homes, where you can go in and do an intensive recovery program, and it might be 1 to 3 times per week, 45 minutes, and you will see the progression. Most people have good muscle memory. Ruth would have had fantastic muscle memory because she would have been an active little person, and she would have recovered quite quickly, up to 5 to 6 weeks. Some people take longer. Now, this recovery that I'm talking about is within the resources that we already have between the nurses who must coordinate it, who work there 24/7, and the allied health professionals and the GP. You can get a good recovery. Over to you, Anthony.
I'll be short and sharp. So I think Ruth's story really should speak to us all in this room, not just as healthcare providers, but really as people. So this was a 91-year-old lady settling into a huge change in life, sort of grasping onto the crumbs of control and small joys she had left. She wanted a microwave to warm up some food, to heat up a wheat pack to soothe her back, the respect and trust to take her own medications. But unfortunately, she was denied of those. And ultimately, these denials really triggered a sort of mental and physical cascade that we heard about. She went from a fiercely independent ex-RN to feeling broken, unheard, and even wishing death upon herself. But I propose that what failed her here wasn't a lack of care, but perhaps it was a system that valued risk elimination and mitigation over autonomy. Ruth's experience shows how a provider-centric model probably failed her, and is a powerful reminder that we can't really call care safe if it strips people over all of the control in their lives. Ruth didn't just need medication or a doctor or care. She needed to be seen, to be heard, and she really needed to be supported to live her life the way she could and wanted to. And this is where the idea of dignity of risk really becomes essential. All people deserve the right to take reasonable risks, because without autonomy, ultimately I firmly believe safety really becomes meaningless.
Okay, thank you so much. A lot of food for thought there, absolutely. We've then got a second question for the panel. But what I might ask, if you don't mind, because I think it really would be useful to make sure that we've got sufficient time for any questions that come through today, is if we could just keep any thoughts and reflections fairly concise to a couple of minutes if we can. So, clinical governance. Anna, what does that mean to you? And feel free, if it's useful, to reflect on Ruth's experience, and I'll also just note we do have the Commission's definition of clinical governance, which will appear on the screen behind me shortly. Over to you. Thanks, Anna.
Thank you. To be quite honest, I had no idea what clinical governance meant. I put it into ChatGPT the other day, and it came up with some options. which I jotted down. So basically, I'm a non-medical person here. I understand it as a group of policies, strategies, rules, behaviours by management and staff that all come together to provide safe and good quality care for a resident. And obviously, just reflecting, every facility would have that, but how good it is in terms of noting it, bringing it to life, will then have these sorts of outcomes.
And I must admit, I'm struck by, given some of the comments here today, the small things really are the big things, aren't they? And I think there were others, Craig and others this morning, that did make similar observations. Mandy.
Thank you, Anna. So I've tried to distill the clinical governance definition that you see up on the screen into something much more simple and has meaning for me as a clinician. So clinical governance describes how an aged care organisation commits itself to provide high quality and safe care in keeping with the older person's preferences. And unfortunately, it's that last part, in keeping with the older person's preferences, that is often overlooked, but clearly an essential part of clinical governance, and this certainly was the case for Ruth. So how then do aged care organisations come to understand the preferences of the people that they care for? The first approach an organisation could take is to become much more actively engaged in clinical governance. Clinical governance isn't just for clinicians. There are many elements of clinical governance which fall within the remit of the non-clinician too, and culture and strategy come to mind here. So when considering culture, what type of culture would support your understanding of older persons' preferences? It would have to be an anti-ageist one, wouldn't it? Too often ageism prevents us from even crediting older people as capable of holding views or preferences. You could also be strategic by choosing a path which deliberately brings your organisation closer to the choices and aspirations of the people you serve. This type of strategy, for example, could be based on what matters to the older person or what good looks like for your older people. As an organisation, you won't get far in understanding your older people unless you also are a listening organisation. This is very important because if you don't listen to understand the older person, how can you be compassionate? Thank you. Compassion involves knowing a person well, recognising that an issue has arisen for them, understanding what that issue means for them, and then doing something about it in keeping with their preferences. So using case studies like Ruth's can also provide great insights into older people's preferences. Some aged care boards start their meetings with a case study because it serves to immediately ground them, their meeting in their purpose. The consumer advisory body reports to boards are also gold. These reports are from people who should be considered experts in their own care, but I'm not sure they're interrogated deeply enough to fully realise their potential. Finally, I would encourage you all to bring lived experience to your work in the sector. Lived experience is increasingly being recognised as offering critical insights for new policy and services, particularly for vulnerable groups such as frail older people. There are, of course, many other ways an organisation can come to understand and to know their older people. Too many to mention here, but very happy to be part of the conversation.
Okay, my version of clinical governance is still wrapped around Ruth and the leadership of nurses. I know that nurses are superpowers. We are the chosen discipline to work across aged care 24/7. If you were reading the progress notes for Ruth every day, you would see that there were problems. So at a clinical governance level, we were not quite monitoring or evaluating Ruth's care if we were looking at this definition to see whether or not we were effective in doing anything. We have that ability to improve trajectories. We can do it for people in our care, right up to their end of life. So we partner and we focus on person-centred relationships. We provide early and proactive planning, not later after something's happened, but very early to prevent avoidable decline or an adverse event. And we address those diverse needs of each person. When I say make healthy normal, it sounds, we're all 21, but it's making healthier normal for the very old. not decline normal, and working collaboratively with our colleagues to give every person in our care the opportunity to improve their function and quality of life.
I thought I'd come at this from a different direction, what clinical governance often isn't inside an organisation. And to me, good clinical governance is written by a clinical expert. It makes an organisation compliant with standards and indicators, but it's often written from inside that person's scope of knowledge. So when there is other evidence which sits outside, and commonly I'm talking about the health and wellness and the reablement space here, often it isn't incorporated well. And so, I came up with a few challenges, like, without a raise of hands, who here in their organisation has a falls policy which outlines how often a resident needs to exercise on a weekly basis? Balance and resistance training or weight-bearing exercise are the only evidence-based falls preventative we have available. In that same policy, who has a directive about what shoes a resident should wear when they leave the bed? Where we know from a recent study that poorly fitting footwear, i.e. slippers, is the cause of as many as 20% of all residential aged care falls. Equally, who has a guiding policy about when residents should attend the dining room? Or a countermeasure when a resident starts to withdraw and chooses to stay in their room? Or starts to move noticeably slower, or demonstrates agitation, or regularly calls out from their bedroom. And if you do have these policies, fantastic. But is this a strong directive for staff to action these activities, tasks, and follow the evidence, or is it just a rough guide that is interpreted by the service deliverer? So, what we need to do is embrace the evidence, and we need to trust in the evidence. And I could go on all day about resistance training and how it works in the residential aged care space, sets and repetitions and exercises, and how well it changes somebody's health trajectory, their frailty trajectory. But in contrast, if you're doing exercise and that fits within your clinical governance guidelines and models, did you know that if you don't challenge the resident with the resistance that they're moving, they can get weaker? They can actually get weaker, slower, and have more falls. So to me, clinical governance must trust in the evidence. Providers want to demonstrate best practice. And it must support the resident to be the best version of themselves, no matter what their age, their level of disease, or their disability. Safe care and compliant care is essential in our sector, but it is achievable. What I think is a little bit harder is actually achieving clinical governance that is determined by the evidence, that is embedded in practice, and that then optimises the client's physical, social, and mental health and well-being.
Thanks, Tim. So, my view on clinical governance is I like to think of it as a safety net and the steering wheel. It's how we ensure quality care is not just by preventing harm, but by putting people like Ruth at the centre of every decision. And under the new Aged Care Act, that's no longer really just a nice idea, it's going to be the law. Clinical governance means having structures, leadership, and organisational culture to ask people under our care what matters to you, and then making that work safely, I should say, and respectfully. It's the mechanism that ensures policies empower staff to act with some common sense flexibility, and that clinicians and providers work together as a team. And I really would like to emphasise the team word, because that is just a culture shift we all have to move towards. Dignity needs to stop being a casualty of protocol. So in summary, from my point of view, good clinical governance is how we embed a person's rights into everyday operations and translate them into action. It's how we make safe, high quality, person-centred care a reality every single day for every single one of the people under our care.
Thank you once again. And just before we move into some of the online questions, and indeed those in the room, should there be any, Anthony, you've mentioned legislation and 1 November and some changes will be coming into effect. I think we're all very much aware of that. Can you see in a clinical governance context some key or material changes? Like, do you think there will be a shift, a point of difference?
From my point of view, like I just said, I think it needs engagement from all of us for that to happen. You know, it's that cultural shift, like I was saying. If we put the person first, then all of our policies and actions, I think, will be a consequence of that. And I think that's really what needs to shift. And I think that the transition to a new act is all just sort of forcing us to move towards that, which is, I think, a very positive thing. So, yeah, that's the way I see it.
Indeed. Thank you. Would anyone else on the panel like to reflect further on that?
Craig, nobody would be surprised to find out that the fact that reablement and wellness are now sitting at the front of support at home excites me. So, and I think it is a good indication that government's been listening, that the people like Joe Boylan and myself who've been standing on a soapbox for so long about the value of these pathways for older adults, independent of the aged care setting, are finally being listened to. So I encourage you all, pivot, change, think about allied health engagement, think about exercise programs, think about training your care staff, because every little bit counts to try to keep people independent in their communities and as well as they possibly can be in their residential aged care settings.
I just wanted to add. Oh, that's okay. I was just going to say that obviously registered nurses are very important. What I've observed are the leisure activity people that are really important too. And what I've observed sometimes is that, you know, and I can imagine me doing exactly the same thing. If I've worked in a facility for 20 years, I've got my basket with all the things to do, and I tend to just do the same activities all the time, you know, cut and paste and colour in and that. What if, in Ruth's case, someone said, let's go and make a vegetarian meal together? You know, let's think outside the square and cater for what the residents like to do. It's not just finger painting and piano playing. That's great if you like that sort of thing. Yeah. But, you know, I think those leisure coordinators or leisure activity managers, they really need to move in with the times and really look at what activities, increase the range of activities available, and they could be outdoor activities and indoor. I've been to so many that have got courtyards. They're debilitated. No one goes out there. No one, the pots are all dead, the flowers are dead, the seats are broken, things are upside down. It's like, wow, why not use this space? So I think everyone plays an important role, but I did notice that the activities, in order to engage with the residents and what to offer, whether it's concerts or, you know, activities, chair yoga or whatever it might be, you can always, there's so much now available just by doing a Google search. You know, I found things for my parents to do while they're in their recliners, you know, put some music and do different things. So just those coordinators play such an important role. I think that we could use them a little bit more, sort of creatively.
Yeah, thank you. Did you have anything you wanted to add?
Yes. In residential aged care, there is such an opportunity, and people are doing it, where we can keep people more engaged, walking right up until they die. Unfortunately, there's only one little sentence in the new standards about reablement, but I'm sure the intention is there, and I'm sure it'll get bigger with more intention later. But you can still feel that is where it's going in the standards, that, you know, very early getting into prevention is key, and moving our lifestyle people into being part of that prevention team is very, very important.
And I'll just add, Paula.
Yes, yes,
sorry.
please.
I think it will change your mindset, but it is
it'll make your life easier to ask the older person first. That's certainly what I found in clinical practice. You know, with older people, you actually can cut to the chase quite quickly if you always ask them first and make that your motto. I think that we need to be increasingly meeting the older person where they are without judgment, because that's what happened to Ruth. She was judged, and we shouldn't have that kind of judgment in our sector. And I think the dignity of risk issue that we talked about, it's really about sharing that risk with the older person. We talk about, either no risk or all the risk, but in fact it's really a matter of sharing the risk with the older person. And you can share that with your multidisciplinary teams. The allied health and nursing staff are really excellent risk assessors, so they can help you in helping Ruth understand what the pros and cons are in terms of her accessing that microwave. But, the history was that she was actually managing that microwave quite well before she came into care, so that would have been my default, giving her a go.
I was just going to, if I can, you've heard me talk about falls, and just on the back of what Mandy's saying about the dignity of risk, often we try to reduce people's risk of falls by actually making them more susceptible to falls. So taking those risks with people, calculated in a safe environment and supported, can actually prevent falls rather than escalate falls for an older adult.
I think we may have fairly well answered this question, but again, I'll just take a moment to see if there's any further comments that anyone would like to make. And the question is, how does the new Act help Ruth specifically? But Mandy, you've spoken about dignity of risk and a few things. So any further additions? Otherwise, we may move to the next question. No? I think we may have a little bit of a technology. Oh no, there we go. I spoke too soon. So what is the recommended practice when older people's wishes on dignity of risks is against the provider's policy, i.e. the wheat pack is not allowed in the facility due to fire risks or other similar issues? Yeah, I thought it might be one for you,
Okay.
Jo.
I'm on Ruth's side, so I'd do a quick little competency assessment, or if I had an OT, I'd do that, a little referral and get the OT to look at her. But personally, it's in the nursing. Sometimes nurses refer off when they are absolutely the right person to quickly do that assessment, and you can see within 5 seconds or 5 minutes really that Ruth can manage the wheat bag. But with Ruth, there needs to be this sense of autonomy. She wants to have feel like she's in control a little bit more, because all of the control has gone. So even if she couldn't do it, we'd be trying to involve her in heating the wheat bag. So there's a whole heap of ways around giving people more control and feel like they're making decisions.
Thank you. Oh, lovely. Yes, I can see we have a question from the floor. Thank you. Over to you.
Hi, my name's Nicole Jackman. I'm the CEO at Riverview Lutheran Rest Home, a small not-for-profit provider in regional South Australia. I really fully support everything Tim and Jo have been saying. So we as a small provider invested $120,000 in a gym, a HUR gym, and we've put in place, we contract out physio services and we put on an allied health assistant. Now, what we've actually seen is some huge improvements in mobility of our residents. We have over 50%, I think 35 out of our 60 residents now are participating in the program. Mobility is improving, their wellbeing is improving, but what we're seeing is that the current funding environment does not support this whatsoever at all. So our ANAC is going down and down and down. So my background is I'm an accountant, so I'm more of a numbers person. We have a clinical care coordinator. So I've kind of graphed this, and what's actually happening now is that as over history, over time, as immobile residents roll off the end, the next person becomes immobile, and your cohort of residents kind of stays the same over time. So your funding isn't changing a lot. Someone comes immobile, they gradually get immobile, they roll off, the next one comes in immobile. What's happening in our facility since we put in this program about 9, 12 months ago is that now our cohort of mobile residents is increasing and increasing, and the people that are immobile is decreasing. I can see it on the graph. It's very visually, because I'm trying to say to our board, justify what is happening, why is our income reducing? So we're spending, $100 grand a year on this program plus the equipment, yet our funding is decreasing significantly. So my question is that as a whole, if providers were to invest money in these types of programs, it would actually save the government a lot of money in the end, because people are not getting to those higher acuity levels. And when our residents are getting to those higher acuity levels, it's in the last maybe month of life, really, that they're becoming immobile. But, the whole system as far as funding and promoting reablement really does not align with the new standards, because in the new standards, say that we need to promote reablement and maintain people's ability, but without putting into place expensive programs that effectively result in you losing money, that is actually not going to be achieved. This urgently needs to be addressed. My question is, at what point do you think that reablement, and how can we get that message across to the government that funding, that reablement and maintaining of mobility is essential to improving both the mobility and mental wellbeing of our residents? Thank you.
Thank you. And I certainly am hearing the applause, and I think the wolf whistles, if you still call them those these days. Look, we haven't got anyone from the department up on the panel. True. It is true, though. Don't know I'm game to go there. To respond to that in any level of detail, I think probably what I could say at the outset is, I will see if there's any comments in response from the panel, noting we are at time, but I would say that your observations have been noted, and I'm absolutely confident that we will take them back as part of the outcomes of this discussion today and convey those clearly to our departmental colleagues, noting, of course, we do have a couple of people here in the room, so presumably they would do the same. So if I've just got 30 seconds or so, in addition to wanting to thank the panel for their time, does anyone want to make a really quick snapshot response?
Okay, I'm going to answer that really, really quickly in 30 seconds.
Yes.
Congratulations,
Yes.
Good for you. You are ahead of your time.
Yes, absolutely. What we need to do is this extraordinary work that's been done on the strengthened standards, which is they're probably the best in the world. What's happened in home care, the same right should be given in residential. So if someone wants to go on a restorative pathway in residential, it should be funded.
Yep. There is things that we could talk about afterwards in relation to how you could fund your gymnasium and stuff like that. But yes, I think what is happening is you're ahead of your time. Like, reablement and restorative care just have not been part of a discussion in residential aged care. And there's pockets of it, and the evidence is all there, but it's not common practice. And like I said before, like the funding is just catching up with the evidence.
Okay, thank you. I think we might leave it there. So once again, a huge thanks to our panel. Clearly, the conversation's just getting started. I think we absolutely could have kept going. And I'll hand back to you. Thank you so much, Richard.
Yes, thank you very much indeed. Paula, Mandy, Anthony, Tim, Joe, and Anna. A wonderfully informative session, and certainly one that has thrown out some very practical challenges. Thank you very much indeed. Please thank our panel as they leave the stage. Now, I do hope that you found all the sessions so far today have been really relevant, as that certainly was, and useful in transitioning to the new Act. Our next plenary session promises to continue that very high level of engagement as we navigate the new registration process. There's been some discussion about that already through the day, but there will be a focus on that at 4 o'clock this afternoon. And as we heard a little earlier, the panel are very keen for you to come armed with your questions. First though, we are going to take a break for just under 30 minutes to give you the chance for some afternoon tea. We'll be back at 4 o'clock for a prompt start. I have also just been asked to mention to you that should any of you wish for one, surgical masks are available at the registration desk outside. So if any of you would prefer to be wearing a mask, they are available at the registration desk outside. Thank you.